Welcome to the second episode on carotid artery disease. Now, this is not a talk based on any article or review of the literature. This is really from my practical experience. And before we go further, just remember this. Carotid artery disease is one of the most important and treatable causes of ischemic stroke, approximately 20% of stroke patients. So, what exactly is carotid artery disease? It is a disease of the carotid artery, specifically the extracranial internal carotid artery, leading to ischemic stroke or transient ischemic attack. One of the commonest sites is the proximal internal carotid artery, the carotid bulb, immediately after bifurcation. Diseases of the distal carotid artery will be dealt with in the upcoming sessions. Now, for practical purposes, I classify carotid artery disease into 10 types based on severity, mechanism, and etiology. It's practically very useful to identify these 10 patterns. And throughout this, one key question you should always keep in mind is this lesion responsible for the stroke or not? Let's start identifying these 10 patterns. 1. Atherosclerotic carotid artery disease. This includes less than 50% stenosis, smooth, asymptomatic, no ischemic episodes or strokes detected on routine testing, either Doppler or MR imaging. Nothing much to be done. Statins, control of blood pressure, risk factors. But the next pattern is 50% stenosis, but symptomatic. Now the patient may have TIA, stroke episodes, or a completed stroke. Here the key question is this lesion really responsible? How do we evaluate? Doppler ultrasound. Look at plaque, ulceration, thrombus, rupture. Vessel wall imaging to identify high-risk features. Digital subtraction angiography. Look for distal or tandem lesions. Distal ICA, embolic stenosis. And don't forget, this may be an innocent bystander. Could be atrial fibrillation or embolism from another source. And if you see infarcts in multiple territories, 3-territory sign, think of an underlying malignancy. Second pattern is 70 to 80% symptomatic carotid stenosis. Now here, you have to decide, is it embolic or hemodynamic? Hemodynamic, very short episodes, weakness, improves on lying down. Repeated episodes, no permanent deficit. Sometimes patients can have limb-shaking transient ischemic attacks. These are not seizures, but a hemodynamic phenomenon. MRI brain may not show much. Usually a tight, smooth lesion, incomplete circle of Willis, embolic, ulcerated, irregular plaque, thrombus on top. One event leaves a deficit. Cortical infarct, wedge-shaped. Management. Hemodynamic, do stenting or end arterectomy. Thrombus, end arterectomy. Always do angiography. Look for tandem lesions, distal disease, M1 involvement, and assess the circle of Willis. Third is near total occlusion, almost a string-like carotid, very thin lumen, produces both embolic and hemodynamic events. These patients can often be treated with carotid artery stenting. Fourth is chronic total occlusion, completely occluded carotid artery. Fifth is pseudo-occlusion, flame-shaped appearance, previously thought to be dissection, but actually, distal occlusion before the ophthalmic artery causes contrast stasis, giving this appearance. Sixth is carotid dissection, intimal tear, false lumen, flow disturbance. If acute, severe deficit, flow limiting, do stenting. If stable, not flow limiting, consider anticoagulation and follow-up. And remember, dissection itself can become an embolic source. Seventh is fibromuscular dysplasia, usually seen in younger patients, especially females. Non-atherosclerotic, non-inflammatory. Typical appearance, string of beads. Can cause stenosis, dissection, or embolic events. Important because management is different from atherosclerosis. Eighth is carotid web, a shelf-like projection, usually at the carotid bulb, often missed but increasingly recognized, seen in younger patients with stroke without traditional risk factors, acts as a nidus for thrombus formation, leading to embolism. Ninth is radiation-induced carotid artery disease, seen in patients with prior neck radiation, leads to accelerated atherosclerosis, fibrosis, long segment disease, often more diffuse, more complex, technically challenging. And finally, 10th, free-floating thrombus, very important entity, can occur over a plaque or in dissection. A thrombus projecting into the lumen, unstable, highly embolic. These are dangerous lesions because they can embolize at any time. So this is a simple way of looking at carotid artery disease, not as one condition, but as multiple patterns. And once you start thinking like this, your evaluation becomes structured and your management becomes much clearer. It's just identifying patterns.